And Abra Qureshi, MD, MPH, is Dr. Qureshi is the professor and chair of the Department of Dermatology at the Warren Alpert Medical School at Brown University and the chief of dermatology at Rhode Island Hospital. He is also very much a public health person, and that is manifested in his global public health work in um, humanitarian work and relief work that he has done and talked to us about in the past, but also in the work he's done in the epidemiology of dermatological diseases and the genetics of dermatological diseases. So he's a great role model for our students in terms of a clinician who's very busy as an administrator, a teacher, a researcher who also has time, makes time to do this global health work, and not only alone with his family, which I think offers for the high school students another sort of something they never thought was possible, probably, and something that they find inspirational, and as we all do. So, without further ado, let me turn it over to Dr. Qureshi.
Thank you so much for the introduction. Really happy to be here. Um, if the end at the end of the next 35, 40 minutes, if all of you are a little inspired to do something on your own, I'm happy to stay in touch and connect you with resources. But we'll talk a little bit about experiences in a couple of different countries over the last maybe decade or so, working in areas where people are displaced, and that is the new term we now use out of respect for folks, for fellow human beings who are displaced. Instead of the word refugees, displacement can be for many, many reasons: war, food, so famine, water, loss of water or food into a certain area, or storms, or natural disasters like earthquakes. So we just use the word term displaced, and you'll hear a little bit about that in the next few minutes. Can you all hear me okay? Al, can you hear me?
Yes, yes.
Very good. So none of these disclosures affect my presentation, but today you hear me say a few words about displaced individuals. So um, let's just get into sort of the discussion. So there are a number of conditions that we see when you're working in a displaced environment. We'll talk about at least one main displaced environment that I spent a little bit of time working in is Jordan, the country of Jordan. I'll say a little bit about skin-related health problems and then overall health problems. And it's hard as a dermatologist, and I'm also a physician. So when you're seeing patients with skin problems, you can't help but notice other problems that are occurring in that displaced situation. And so you learn a lot and you hope that you can do something about it. And we'll talk a little bit about some of these problems that we see. Some of them are related to just people being displaced with no shelter. So weather-related issues, sun damage, et cetera, overcrowding. And then overall health problems, typically you can imagine someone living in a displaced environment for so many years can result in several problems, especially health related, so nutrition related issues and problems with just general health care. So the story for today, thank you for joining, late tonight. Appreciate it. Today's story really begins. Yeah, this is my first trip. I took this picture back in, I think, 2016, in the city of Amman, Jordan, and it was my first trip there, and I didn't know what to expect. I landed, it was early in the morning, and I was, part of a mission trip. There were 65 physicians and dentists from the U.S. that the Syrian American Medical Society had sponsored to go to Amman, Jordan, to work in refugee camps for Syrian refugees that had come across the border from Syria into Jordan, and they were displaced. So we were working with SAMs. Whenever you do work with, in any country in the world, you want to work with an organization that has boots on the ground. That's lesson number one for tonight. So you want to liaise with somebody or a group of people who've done it before, who have boots on the ground. They're there, they're present. So when you get there, you have access to resources where you can begin work. Otherwise, you can land up somewhere and not be able to do anything because the local authorities may not allow you to do things, etc. So this is one of the pictures I took in Jordan. It's interesting. A lot of the buildings there are made of this very interesting yellowish sandstone because it's mined over there. So the bricks are made from that stone. They're beautiful roads. It's sort of an interesting city. It's very high up in the mountains. So the climate is quite cool. It's a beautiful place otherwise. But we were not working in the city. We were working in the outskirts of the city and all over Jordan, taking care of people who are displaced. So if you look at a map of Jordan, you'll see Syria next door. You can imagine how the folks displaced from war had come in. The war started in 2012, 2011, 2012, and so we were there about 5 years later, taking care of these people. So this is one of our first briefings. So when you come into a situation where you're working with displaced populations, it's very important to do two things. They make sure that you can be identified amongst a crowd. So you have to wear an ID and you have to wear some identification to clothing so they can recognize who you are in case there's an emergency. They got to get you out of there, etc. So in the briefing room, the most important lesson that we learned was, when we work with people displaced, we can't promise them anything in excess of what we can provide in terms of local healthcare. We just can't, make any promises about going somewhere, especially with immigration, movement across borders. We can't leave any money behind. We can't give any charitable gifts, et cetera, because that's not our job. Our job as physicians or healthcare providers was just to provide the medical care, provide free medications that we brought with us or that were given to us to provide, but that's about it. The question actually, this instructor, the person speaking there, has become a really good friend over the last decade. He's actually Syrian origin, but he's a happens to be an accountant from Chicago. I mean, can you believe it? So he had come and he was my translator. I speak a little bit of broken Arabic and I can understand most of it. But Raed had come from Chicago. He's an accountant, but he came in because he wanted to do something and he wasn't a physician. So he said, "What can I do?" And they said, "Well, you can come and translate." So he was actually in Arabic we call mutarjim. He was the translator, and so I got to know him really well. He's a very funny guy. So this is him debriefing all of us in the first briefing we got, and the number one question he asked us was, when you're, if you have to run out of your home and you have less than 10 minutes to leave your home, what would you take with you? And I can tell you, there were maybe 20 of us in the room. This is the front of the audience. Um, and guess what? All of us got the answer wrong. Can you believe it? So does anyone want to guess what you would take with you? You can unmute yourselves and just tell me what if you had like 10 minutes to run from your home. I don't know. There's a earthquake coming, there's a hurricane coming, you gotta evacuate quickly. You could walk, you may be able to drive your car or not, you don't know. Let's say you're walking, you're running out of the house. What would you take with you? Any thoughts? Any guesses?
I would I would throw out a couple of things. Important documents, medications, our handy little backpack that has hopefully all that stuff packed in it, if we had to, our little go kits. Those are a couple of things I can think of off the top of my head.
That's excellent, Glynis. Anybody else?
Well, Lewis here. I think water might be important, and I'm also assuming that we've corralled our family, and everybody who lives there is on board with an exodus to the same place. So
Excellent. So both excellent thoughts. So both of you said two important things. The number one priority, according to Riot in that debriefing, was you got to bring your identifying documents. A document that identifies who you are is critical because when you are running or when you're moving and displaced, nobody knows who you are. And unless you have a form of identification, especially a passport, a driver's license, a diploma, something that tells someone about you is absolutely critical. The second thing you do is you do a man count or a human count. You figure out children, pets, anyone who is living in your home should go with you. You don't leave anybody behind. So absolutely correct. It's interesting enough. You do bring water, but guess what water is? It's the heaviest commodity you can carry. So you can carry just enough until you get to the next location, but you bring enough drinking water. So number three, so one was documents, two is humans, everybody with you, and third is medications, as Clint said. So you want to bring your medications with you as much as possible. So anyway, so that was the first debriefing. And then, as we leave that room, we went to the supply closet. There's usually a pharmacy. So the city of Amman, Jordan, and the Jordanian authorities, Jordanian Health Authority, had through SAMS had given us health licenses or medical licenses, I guess, to practice in the country of Jordan for 1 week while we were there. So we were working in United Nations High Commission of Refugees camps and other local camps. So we had the ability to pass out medications for free. We had the ability to practice medicine during that time. And so this is also packing suitcases with us from the pharmacy, or there's a room in the hotel where we were staying where we had all our supplies stocked, and we sort of packed as much as we could before we headed out to the camp. So each group was heading out to a different camp. This is one of the first camps I went to. We were in a bus of about 12 physicians and dentists and pediatricians. This is a classic United Nations High Commission for Refugees camp in the desert. This is, I think, January, so it was a little cool in the desert, about 60 degrees during the day. So it gets pretty cool at night, almost 35, 40 degrees, just about freezing point. And these are metal containers. You can see how the camp is laid out. It's metal fabricated containers, and they are all wired with electricity. So this is a well-organized UNHCR camp. Now, as you know, we're very proud as Americans because, so far, our country funds a lot of UNHCR work that happens. Interestingly enough, the physicians are funded through a separate agency called the International Medical Corps. Now, as we're driving through, this is an example of how heavy water is. There are watering stations at different points along the camp. And so you can see people are quite heavily clad. Someone's wearing a hat with, a jacket with a hood, wearing a hat. It's pretty cold there. This is watering station number 1. You can see, so clean, potable water. They can fill up containers. Any form of wheels or transportation you can find, people carry water with. A wheelbarrow is probably the best, form of transport. If you have a wheelchair, you put the water in a wheelchair. Any form of wheels, because the water is so heavy to carry, and they're trying to bring the water to their respective camps. Now, some UNHCR camps actually have water delivered to the actual tents themselves in containers. You'll see them in other camps. I'll show you in a second. But this is sort of how it's done. And this water is very, very pure, clean to drink, and high quality. So they're getting good quality water, so they don't get any communicable diseases through the water. And as we're driving through, another reminder of the camp, this is a well-fortified playground for kids donated by one of the organizations, probably I want to say UNICEF, but usually the boards are found. And it's fortified because kids from different sectors of the camp are allowed to use the playground at different points in time. The most valuable possession for a child, and you see pictures later, is a soccer ball. I mean, if you have a soccer ball in your possession, you are queen or king. And this is a classic, AstroTurf playground. And it's good that these playgrounds are there because most camps don't have them. The well-organized camps, do have them, and they put up very quickly, modular framework, and kids can use them at different points in time during the day or the week, depending on which sector of the camp they come from. Now, you can see it's very cold in the camp, so they use everything in the wintertime to shield against the wind blowing across the desert. Some of them, almost every displaced person has a cell phone to a family or more, and they almost all of them have these antennas they buy to put up so they can get transmission of signals, so they can watch news, etc. They're almost always glued to the news at all times. You can see these are well-powered camps, others are not. This is the IMC, so International Medical Corps. This is the agency that basically supports physicians. So when we go and work as physicians from the US through SAMS, Syrian Medical Society, working in these camps, we are actually training IMC doctors and nurses, because when we leave, they carry on the job, after we're gone. So when specialists go in, they love working with us and providing the care. And I took this picture because I was proud to see, of course, our flag up there, and of course other countries up there as well. With time and the sun, colors tend to fade, but you can see UNICEF runs this part of the camp, and the US is involved in funding and supporting these camps. I've taken so many pictures over the years, but even in the last decade or so, this is probably the most striking image of a child I've ever taken. This was at one of the camps called Azraq Camp. This is in the north of Jordan. So it was about an hour and a half, 2-hour drive from Amman, and right on the border. This was an early the settlers camp, meaning the people who had come across into the country, into Jordan, were being processed for security reasons through this camp, through the local Jordanian authorities. So not all families were together. So as people would trickle in across the border, they'd be identified with identifying documents and put into different sectors of the camp, depending on security clearance for entering the country, and then they'd be kept in the camp in that area. So, this is a young girl, and you can see there's a number of things you can notice about her. First of all, she's wearing a pullover, a sweatshirt that probably was donated from a U.S. source. You can see it says Phoenix on the front. It clearly is small to her. She's growing out of it. But it's interesting. She's about 16 years old. She probably looks like she's 12. So there's a lot of growth stunting in the camps. These children are, not getting enough nutrition. She's wearing gloves. Of course, it's chilly enough in the desert to wear gloves. And what's surprising about her, we just arrived at the clinic. We were unloading our vehicles and getting our supplies out. And I noticed her standing in the corner. So I took this picture. And I'll never forget, it was this really odd look of, the best way I can describe it is, it was a look of um, annoyance and distrust, if you will, in the situation she was in. Some look, some sadness, and some dismay. But generally, someone who is not happy. And we got to know her family a little bit. They had a number of other skin issues, but she clearly had been in the camp for about 3 or 4 months at the time. This is a classic, clinic in the camp, some of these early camps. So once they get processed out of this camp, they go to a better infrastructure camp where there's, better housing. But in the camps right on the border, when they're coming and being processed through security clearance, which sometimes takes days to weeks, these are the kind of the tents we have. So you can see a UNHCR symbol there. This is a pretty large tent, and inside the tent, you can begin to see there are sort of exam rooms. You see, all the people are lined up outside. They heard there's a clinic there that day. They're there. You can see someone's carrying a backpack that has the Saudi government's name on it. So maybe the Saudi government donated those backpacks. Everyone's pretty well clad. It's quite cold in the desert that day. They're wearing, warm clothes. Like I said, you can't imagine, but the desert gets really, really cold at night. Um, this is the inside of the tent, and you can see small exam rooms built with sort of makeshift sheets and canvas and tarps. So you can see small entrances to each room. I got that larger tent, the white tent room, because I was seeing people would have to take their clothes off to have their skin examined. It was very, very cold there. So they gave me the closed tent with a small little heater. That was the inside of that tent. There's a small heater there. You can see in the corner. And all my supplies on the table. I have just one chair, an exam table on the other side, and a trash can. So not bad. I mean, I'm in the tent. Now here's the scary part. This is our autoclave. An autoclave is a device we use to sterilize instruments. Well, we can't do too many surgical procedures. We can drain abscesses, remove things surgically, like tumors, but there's nothing to sterilize instruments. So I didn't take a picture of the inside of this pot because that day this particular propane tank caught fire, so we had to be rushed out of the tent. And luckily, it didn't explode. But it's a propane tank at the bottom with a burner on top, and on top of that is who knows what's sitting on top of that? Any of you cooks or chefs? What do you think that is? What kind of pot is that?
A crock pot or a
Close,
Pressure
very
cooker?
close. Say again?
Pressure cooker?
Pressure cooker. Good job, Carrie. That's a pressure cooker. So remember, your pressure cookers need, you got to hear the whistle go off. Anyways, that's a pressure cooker. So inside the pressure cooker is a layer of literally Pepsi cans, if you will, or Coke cans, metal cans half full of water. On top of those cans, we lay out our wash instruments, and then you close the pressure cooker and you turn it on. So the water in the cans heats up, boils, steams up, and then basically those instruments lying on top of the cans get heated and sterilized, and we had to wait for 3 whistles apparently. So you get 1 whistle, second whistle, third whistle, and the instrument's sterilized. I mean, that's the best we could do. The problem is we couldn't package instruments. So normally in the US, when we autoclave things in a special autoclave, which is a special boiler or heater for instruments, they're packaged inside a special container. Actually, it's like a half plastic, half paper bag, if you will. So when you take the instruments out, they're still sterile inside. You open them on the surgical field. Here we didn't have that. So all you had was instruments that maybe were heated up and boiled and sterilized. And then once you opened the crock pot or the pressure cooker, air would get to them and they could become unsterile. So be careful. Once you had the instruments ready, you go right to surgery and then bring them back, wash them in the sink, scrub them down with a special brush, wire brush, and then put them back in the autoclave. So that's kind of how we autoclave things. This is an example of one of the refugee camps. It's a very well organized camp. It's called the Zatari Refugee Camp. I spent many, many days working in this camp over the last several years. Very organized camp. This is an example, a picture of a dad and a child waiting to go into town. They got special permission to leave the camp. And you can see, if you can tell, who can tell what's going on with the weather that day? Can you tell on the pictures? Can you all see the snow? It's basically it's so this is a desert. No one believes me, but it was snowing that day. I mean, it was just a little dusting, but there was snow and it was pretty cold. And you can see the little girl, she's quite laissez-faire, kind of happy-go-lucky. Dad looks a little more serious. They're waiting for the bus to take them into town. They're probably going to go either visit some relatives or bring some groceries back or bring supplies they can't find in the camp. But they're waiting, and you can see behind them how fortified the camp is. The displaced folks cannot leave the camps. They have to go with special permission. They got to come back within the next number of days. So this is a different camp, sort of an older camp kind of, you can see here, each tent or metal structure has its own water supply. The white tanks are water containers. They're filled typically once a week. There's only one tap of water inside. If you let that water, if you somehow leave that open by mistake and water drains out, you're done for the week. You can see the bus in front of us that's carrying physicians and nurses and dentists, and same with our bus. This is sort of the inside of a different clinic, an older clinic. You can see it's all been put together with metal containers. This is one of the managers, Jamal, is managing the camp. That's me. And you can see in Arabic written on the door is a word that says jildiya. Jild in Arabic means the skin. So that's the skin clinic. This is probably the most valuable commodity I can pass out to a mom who brings in a baby with a diaper rash. Moms will do anything to get a few diapers because it makes their lives easier. They have cloth diapers they got to wash. So if you can get a break for a couple of days and have disposable diapers, they'll do anything to get their hands on them. Desitin is actually a diaper rash cream, and clotrimazole is an antifungal cream just to prevent diaper rashes. So a huge commodity in the camps. So I'll show you some clinical pictures if you want. None of them are really, you can eat dinner through them if you're consuming it, you'll be okay for the most part. So, we see a lot of skin conditions. This is a classic, it's a baby with impetigo in the cheeks. You can see, a baby's been scratching the face, got a couple of larger nodules. And in the center, you see this red area that's eroded. You see almost this yellow honey-colored crust. So it's just a good old staph infection. Kids will spread it to each other very, very quickly. So we typically treat them with topical antibiotics, rarely oral. If the infection is deeper, we'll give them more antibiotics, but usually for topicals, they clear up. And we try and treat all the children in the family. So if there's 3, 4, 5 kids in the household, they're living in one large room in a tent, they easily transmit the infection to each other. So this is a good old simple bacterial infection from Staph aureus. This is a child with a more advanced infection. You can see almost cellulitis of the eye. So the orbit, the area around the eye is completely swollen. You can see an area of pus. So we actually had to hold the child down, little bit of anesthesia. We just drained it with a little blade, got some pus out of there, and we put the child on antibiotics when we sent them home. So we also worry sometimes if this child has recurrent infections, could they have an immune deficiency disorder? And so we always watch these children come in to see us in these camps to make sure they don't come in repeatedly time and time again. This is another bacterial infection, just good old folliculitis. This is a young lady, probably shaved her legs with an old razor. Didn't have much access to water or other amenities in the camp, and just spread bacteria along the leg where the shaving occurred. You can see linear changes where the shaving occurred. So it's good old folliculitis, infection of the hair follicles, bacterial in origin, and we just gave her an antibiotic and it cleared her within 4 or 5 days. Now, interestingly enough, in the camps, we see a lot of odd things. I couldn't understand what was going on for the first year or two I went there. And then I realized. So essentially, this is extreme dryness in the desert. It's very, very dry. In the winter, it's cold and windy. Summertime, it's hot, but generally very dry. So what happens is when they walk around, without any protection, and especially with not much footwear, the feet dry out, the hands dry out, and they start cracking and fissuring. And we really, really worry about these cracks. You see the cracks that are bloody on the hand and the feet. Interesting enough, if bacteria get into these cracks, they get what's called an ascending cellulitis, which can land them up in the hospital. So we have to, basically treat these people, carefully. A lot of what we do is have them use grease. So if they have olive oil, a lot of olive oil available there, use olive oil, or we bring lots of Vaseline with us. Some of the companies donate Vaseline to us. This is a family with 3 children. All of them have the same problem. So one child came and I said, all of you get onto the exam table, and they all had the same problem. When I work at the VA hospital, my Vietnam vets remind me, they say, Dr. Qureshi, I got jungle rot, which is because they live in wet climate conditions in Vietnam for days with heavy boots. And a lot of our vets got these severe fungal infections between the toes. This is the exact opposite of jungle rot. It's kind of a rot of the feet, but it's dry rot, if you will. And so, if you notice, there's some yellow color on the feet. I've painted iodine. Iodine's a good old antiseptic. So we paint them with iodine and give them lots and lots of Vaseline, have them use that olive oil, or have them use, footwear that they can cover their feet with. So good socks, good quality socks. I'll bring some warm socks sometimes for some of these kids with me in my suitcase, and or good footwear to protect these feet. Very dangerous because if the foot gets infected, sometimes you can even have a severe infection and go to the bone and result in amputation of the foot. So, pretty scary. Now, this looks like just a regular itchy rash on a baby's belly, but this is classic scabies. So scabies is a mite that lives on the skin, and in overcrowded conditions, just overcrowding, it spreads like wildfire across populations of people. So it typically through contact, but you can see how it's around the belly button, that area. See small little dots all coalesce together. So when a child has it, I always ask mom, and that day mom had brought the baby, and an aunt was with the baby. So I asked them to see their arms. They said, no, we don't have a rash. I said, well, you itchy? They said, yes, we're itchy. So I had them both roll their sleeves up, and guess what? They had scabies too. I mean, the whole family had scabies. Now, in Arabic, the word for scabies is jarab. And, I learned early on in the, working in these populations, that you never ever use that term because it's considered a term sort of derogatory because it suggests that, people don't have the money to, living in overcrowded conditions. So we don't use that term at all. We'll just use the term, it's another term for mites, but essentially everybody needs to be treated. So this is very tricky to treat. Scabies is very itchy. It can result, in poor sleep because the itching happens at night. So, and we got to treat the whole family. So typically what we do is, good. So here's the strategy. You treat everybody with a cream. They apply it ears down at night, and they put on new clothes if they can get laundered clothes. All the old clothes that they've worn the last couple of days, instead of washing them because you can't wash them all the time, they don't have enough water, we had them seal them into garbage bags, large, clean plastic bags. The mites cannot live off the skin for more than 4 to 5 days. So in the US, will tell you, hey, just launder your clothes. Can't do that in the desert, right? Can't do that in displaced population. So we've adopted a new strategy. We actually give them the cream to treat themselves with, and we give them clean, large plastic garbage bags. And so what they'll do is they'll take their bed sheets, etc., their comforters, will put them into the bags, and they'll seal them for 4 days. The mites typically will die, and then they can use the same clothes again without washing them. Mites are so small, they're like dust. But if you don't treat the whole family, it spreads to another family, and it spreads like wildfire through camp. So we really want to jump on this and treat them. And again, like I said, this baby, and that's mom and aunt. So in the same visit, I was able to diagnose 3 people, probably the rest of the 6 or 7 family members. So very important, pick it up early. It's another child with early scabies. You can see looking, nice and peaceful, but you can see a few bumps on the cheeks and the forehead. There's early signs of scabies as well. We do see a lot of tinea, so fungus in the camps as well, because it's very transmissible. So this is a patch of hair loss on this child's scalp. And you can see tiny white dots. That's basically where the fungus invaded the scalp, and essentially the hair broke off there. Why the hair break off? Because when the fungus invades the hair becomes fragile. It just breaks right off, right when it's coming out of the hair from the scalp. So typically, there's one fungus type that causes this in the camps, and we typically will treat them with an oral antifungal. Griseofulvin is the name of the drug, for X number of weeks, so till we get them better. Now, one child has it in the family, the other kids get it too. They do get it from they play with, there's some dogs in the camp, they get it from the dogs sometimes as well. So again, it spreads like wildfire in overcrowded conditions. And I'll say, in the US, I'll probably see teenage capitis once or twice a year. There, every clinic I do, I have several kids who come in and they have teenage capitis. We also see a lot of warts among children. Interestingly enough, this is very extensive warts. This child is not immunocompromised. If I see warts like this, I always ask the question that could the child have HIV disease? Could they have something else going on? Luckily, in this case, the child is healthy. They're doing pretty well. So have warts, so we treat them typically with salicylic acid. We don't have any more advanced treatments, but it's difficult to manage these in the clinical setting. And then, of course, there's a lot of stigma around depigmentation. This is a condition called vitiligo. In individuals you see who have darker skin, unfortunately, they get very ostracized. We do a lot of time educating them about this condition. It's not contagious. It's just depigmentation of the skin. It's called vitiligo. It's quite benign, quite normal. We try and get them to repigment, but we always test these people for their thyroid function because they tend to have thyroid disorders. And so we always screen them for that in the clinical setting. And then the other crazy thing we see, and this is again part of being in the camps, is a lot of the displaced folks, right, they live in very congested environments. So the whole family living in one container, if you will, one room. And so in the cold months, they actually light a propane heater, and it's well exhausted, but it's hot. If a child, if they boil water for tea or they're cooking something, and a child walks in the pot or walks in around, where the stove is, they get burned. So these all burns on children. I mean, there's burns on the neck. You can see from scalding hot water that fell on the child because of, again, overcrowding. Someone bumped into them. They had a hot cup of tea. It was boiling hot. It burnt the child. There's the baby who had something spill on them. I think it was oil. Mom was, cooking something. Baby was in her lap. It's such close quarters, got burnt. Now these are keloidal scars from burns. This is a more fresh burn on the belly of another baby. It's fascinating, right? So because people are doing the same things again and again, we'll see the same things, in the camps, which we never see in the U.S. Like I would never see this. This is just doesn't happen. Mom sitting on the ground, she's trying to cook on a propane heater. Propane heater is above the child. Child sitting on the belly or on the chest breastfeeding. Something happens, gets splashed, gets on the kid's belly, and boom, you get a burn. So isn't that fascinating how you see patterns of disease in certain areas? So of course, we have all the supplies for them. We provide the supplies for burn care, and help them out. Another two burns. I mean, one child had, both two kids had, hot liquid, either oil or water, fall onto their on their thighs, and they got burnt, one worse than the other. You can see the one on the left side of the screen. This person had a more recent burn. You can see whether the container was a cup, I guess a cup of tea fell. You can see out of the cup and then the tea fell onto their skin. That's a blister. You can see blisters beginning to tear, and that's where the burn occurred. It happened in literally a flash, 2 seconds. Very hot water or oil, boom, it got exposed. In 1 second, like 2 seconds, the burn occurred. And you can see that the picture on the right side is a deeper burn, a second-degree burn, very, very painful. But what our goal is to make sure it doesn't affect the joints, doesn't affect movement of the joints, doesn't affect function. So we do a lot of work to take care of these burns to make sure they don't get, other problems happen. This is my team. Actually, one on the right side is one of my kids and working with me that day. They're counseling a mom. So typically what I do is I work with teams of medical students, and so they'll work in a large room. So let's say this room had 3 bays in it. I'm running between the 3 bays. I have medical students working with me, seeing patients in every bay, and I'm running from one room to the other, seeing 150 patients a day, and talking to them briefly about what to do and the next step. And so behind us is our shelves of some supplies we bring with us and shelves of supplies we have. We'll basically talk to them, give them the supplies, and then we will write down what they have. What you'll also notice is, I don't know if you see that or not, but you'll notice is that on the table, and the gentleman on the right side is holding a blue small book with a piece of paper in it. That booklet is actually their medical records. It's the UNHCR medical record booklet. So in the US, I'll write a long note. I see a patient, I write a long note, right? There, I'm writing 2 words, the diagnosis and the treatment. That's it. And the date and my name and signature. So over the years, I've seen my signature back a few years later, and unfortunately, I made the right diagnosis, which is good news. But it's good to see patients back a couple of years later. If the kids, they've grown older, it's good to see them back, and you can see the old signatures in the booklets. So we also will give them some handouts on what they should be doing, and we'll put that into the booklet and pass it on to them. So that's how we do it. But this is a classic example of a room. You can see some of them wearing jackets because it's pretty cold, even in this metal container. I'll never forget this child. I saw this child, and saw her with her. So this is a picture of her as a baby, and on the right side is a picture of her a few years later. But then this is her. I saw one day we're leaving clinic. Dad came running and said, "Oh my God, I heard there was a Dr. Julia, a skin doctor here. Can you help me?" So she had a hemangioma on her face. We had to get in touch with our pediatric dermatologist back at Brown University, and they helped us manage her. And then you can see the hemangioma became smaller and did not affect her eyes or her vision. And eventually, I saw her later, 4 years after this, and the lesion had completely regressed. It's a benign vascular lesion. We want to make sure it did not affect her eyes or her vision. And rarely, then, just the last couple of slides here, and then we can end and go into questions. An example of sometimes we'll be, running around clinic, and suddenly we'll see somebody, and they have a rare condition. This is a child with a rare genetic problem. It's called ectodermal dysplasia. They have abnormal nails. Their hair doesn't grow properly. They actually don't sweat. It's called anhydrotic ectodermal dysplasia, where they don't sweat at all. And so it's very dangerous for them in the desert because the parents can't understand what's going on. So we had to counsel them, follow up with them. I mean, we just made the diagnosis by seeing the patient. And, her teeth are slightly abnormal. The hair doesn't grow fine. Otherwise, healthy longevity if we can protect them from the heat because they don't sweat. It's called anhydrotic ectodermal dysplasia. So anyway, sometimes you stumble on these rare cases that you can really help out with. This is a child with trauma at birth. They used a suction device to pull the baby's head out. This is permanent, damage to the scalp. This is a patient with tuberculosis of the mucosa. You can see an abnormal change in the mouth, swelling of the mouth. You can see it wraps around into the mouth there. And then lastly, last couple of pictures. I mean, this is, this kind of stuff you also see. This is a child. This is Muhammad. He is a youngster who's paraplegic, basically was born with spina bifida. So essentially what it means is that his legs are paralyzed below the waist, right? So it's a birth defect. Now, that's his wheelchair. At the bottom, you can see, I put a picture of his wheelchair. It turns out he was getting these ulcers on his back because he'd be sitting in his wheelchair, and where he's sitting, pressure from the bones is causing the problem. So all we did was we taught mom this very simple move. We just taught her to just put these special pads. We gave her a lot of supplies that could last for, let's say, 6 months, with special padding and tape it down. So when he sits, his buttocks are sitting on the pads, and the bone in the middle is suspended to air, so there's no pressure on the spine. And guess what? One of the volunteers in clinic messaged me 2 weeks later and said, he came back and he's completely healed. He didn't need any other special treatment. He just needed pressure taken off the spine. He spent all day in his wheelchair. So, very happy-go-lucky child. But he was just suffering with a very simple problem, and we solved it with just changing. Now, of course, in the US, we'd have a special device. We could design a special chair. Can't do that there, but we can certainly modify and sort of play with the resources we had. So we just took some special pads, showed her how to roll them, stick them down in his chair, and he was healed in a few days. Let me just end with this. So a couple of cases, sometimes we see some skin cancers in clinic. These we can deal with surgically right then and there. This is just a basal cell carcinoma on the nose, another one there. Then, believe it or not, this is actually a tumor on this woman's face. Can you believe it? Now, luckily, she covers her hair so she can cover the face. This is the benign cylindroma. Be able to get her out of the camps into a local hospital in Jordan, have it excised, and she did very, very well. But this has been growing for 15 years, and it's benign. Now, I know it's benign when I saw it because I've never seen a tumor this size ever in my life before. But I knew it was benign because it was on her face, it had grown so big, and she was still alive and talking to me and hadn't invaded into her mouth. So I knew it was benign, just needed surgery under anesthesia to remove it. This person died, unfortunately. He had a severe squamous cell carcinoma of the orbit, lost his eye, and then eventually, passed away of metastatic disease. And then just want to end with, the positives. There's so much hope in the camps. I mean, these are youngsters, they're growing up in the camps. You can see displaced for years. Some of these kids don't know anything but the environment of the camp. You can see it rained a couple of days before, so there's a lot of water in the streets, etc. This is an example of something silly. We now carry weighing scales with us. On my first few trips, we didn't have any weighing scales. So Rana's a nurse from New York. She's worked with me a couple of times. So essentially, we couldn't figure out what antibiotics to give the kids. So what we would do is this is how we'd weigh them. I would lift a child, write the weight down. Rana would pick up a child, write the weight down. We take an average. And that's how we weighed the children to give them antibiotics. Of course, now we're better. We bring weighing scales, but just tell you how you improvise, in an environment where you have nothing accessible to you. And then finally, the most recent thing last year, I was there and I couldn't figure out why. A lot of women were coming in and they were complaining of hair loss, and I couldn't figure it out. Took me 4 or 5 days. Toward the end of that week, I realized they were getting hair loss because they were anemic. So this is just an example of their conjunctiva, quite pale. If you look at your own conjunctiva in the mirror, you'll see it should be bright red. So these women are anemic, and anemia and malnutrition is causing the hair loss because when they're pregnant, they have multiple babies, they're not eating much meat. They eat, barely any veggies, so they eat, very poor diet in the camps. And so because of that reason, they're getting malnutrition and iron deficiency. So we're working on a program through several agencies to provide folic acid and iron supplementation to pregnant women. But again, this was a realization. I was seeing hair loss. They were complaining about hair loss in dermatology clinic, but the hair loss had nothing to do with the scalp. It was actually malnutrition and loss of hair. My last slide, this is Hariri. He's one of our helpers, one of the locals, was also displaced from war, but he settled in. And when you're busy, seeing 150 patients a day, running between things, no time for lunch, maybe some water here and there, Hariri would show up with highly sugared up Nescafe instant coffee. And every time I've been there, he knows I love that coffee every couple of hours. So he'll show up and he'll just get me the coffee, and somehow I'll enjoy the coffee between patients and keep going for the rest of the day. So it's a Nescafe instant along with sugar. And maybe I'll stop here and happy to take any questions. Thank you for your attention. Thank you for being here tonight.
Thank you. Thank you. We have a couple of questions in the chat, but Glynis, why don't you ask your question, and then Lewis?
Thank you so much. This was awesome. Thank you. Really appreciate it. I'm thinking back to, I was a new graduate nurse and did dermatology on the side, but nothing like this. So yeah, wow, this is cool. So cool. And thank you for your service. Appreciate it. I was just curious. I know that you conduct education while you're there, but what is the ongoing health education that's done to either try to prevent, like, for instance, the burn injuries that you showed and other skin conditions after you leave and ongoing?
No, it's a great question, Glennis. I mean, that burns are so easy to prevent. So we've actually recommended that all, basically hot stoves or space heaters be in one corner, and there be a barrier put between that and the rest of the room. Now, the problem is, what do you use as a barrier? So people have been very creative. One family used an old bike frame. Like basically the bike was it didn't have any wheels. It was kind of, rusting, but it's a frame. So they would use this bike frame to block off that section of the area so kids couldn't wander in there. And then when moms are cooking, they do not carry the babies with them. They either feed the babies and they're just doing that only, or they're cooking, but they're not doing both, or dads are helping cook, instead of feeding babies with a bottle. So we've tried to implement some of these simple strategies. It's interesting. The most important, it's actually fascinating. The most important aspect of maternal and child health is teaching the moms to breastfeed. So we never discourage them from breastfeeding because, child's health is so important there. So we always, tell them to find a way around it, but definitely not be breastfeeding while they're cooking because that is so dangerous. There's so many babies, get burnt during that time. So that's been our main thing. The other big one is if we can spot scabies, if the IMC doctors can spot scabies early and you catch the first family, the first index cases, you treat them, boom, you got it. If you miss the first few families and it spreads like wildfire, it's very hard to contain again. And then we do carry some sunscreen and sunblock with us. They love sunscreen. They love skin products. We can't carry a lot with them with us, but we do carry some for the patients who get sunburned easily.
Thank you so much.
Louis, are you there?
Yes. So, yeah, can you hear me?
Yes.
Thank you very much, Dr. Cressy. A couple of things I really think are important to that you mentioned. One is to have a medical license approved by the government. I think that lends a real strong validity to the whole process, and an agreement by the government for presence of workers dispensing medicine. I remember getting a license to practice medicine in Zimbabwe, and it was a rather elaborate document that I still have around. So I think it's important to have that, um, just to make sure that what you're doing is in line with the government's and the government knows where you are. And the second thing is the medical record is so important. Of course, it'd be nice to have an electronic record, but that record, people carry WHO cards or what the kind of refugee cards that you mentioned, and they carry those in Africa, for example. Those are just so valuable for any practitioner to see the child. My question is more about probably continuing acute care, how that continues on. Do other groups come and take over when you leave, or is there acute care services? And then the other thing would be sort of ongoing public health care, immunizations, addressing social emotional issues, sort of chronic conditions that people also have. A follow up for acute care, and then follow up on public health, preventive medicine clinics. Thank you.
Louis, excellent comment about the medical licensing. It gives a lot of legitimacy to the practitioner. I'll tell you, it's interesting. My passport actually has this weird barcode, and I couldn't figure out what the barcode was. And many years later, I realized it's actually a UNHCR barcode. So once you enter the camps, they actually scan you, make sure you're legit, and you actually can't. They've actually refused entry to some of us on our team who weren't processed through the UNHCR portfolio. So it's interesting, it's very well protected, which is good for the patients, of course, and for us. Acute care is very, very difficult in the camps, but I would say it's better than chronic care. Chronic care is completely absent. It's purely reactive care. So the IMC, the International Medical Corps doctors and nurses that are there, their job is to deal with, acute issues with maternal health. So pregnancies, childbirth, C-sections, acute infections, et cetera, et cetera. Cancer is the worst care possible because someone's got a slow-growing tumor. The guy I showed you who died of, metastatic disease from a squamous cell carcinoma in the face, easily preventable. They just wouldn't touch it. It kept going bigger. By the time I saw him at a biopsy, it was too late. He died 3 months later. So chronic care, high blood pressure, type 2 diabetes, very difficult to care for. It's mainly reactive therapy and care, definitely not proactive. But certainly they're moving more and more towards that because they're realizing if they don't do prenatal care, they're going to have a lot more emergencies with obstetrics, right? It's very common sense. So they can screen them off of blood pressure, watch the babies, they'll have fewer emergencies, right? But it's taken so long to implement. So a lot of it is, can you solve a problem but not prevent it?
Mm-hmm. Yeah, it seems like there would be a lot of social emotional issues as well.
Huge mental health. Mental health is a big. So we always have social workers with us. We always have psychiatrists with us. It's very difficult. I always tell a story. I never forget. I've seen her a couple times after that. One of my first visits back in 2016, she came in. She was an older woman in her, basically maybe late 70s, early 80s, and she came in and what she told us was she had no skin problems. She was just seeing us because she wanted to see some human beings, and she saw a busy line. She thought that the doctors might be nice to talk to, so she stood in line for 2 hours and then came to see us. And when I said, shuf, like, what's Jaldia? She said, nothing. I'm totally fine. I just lost my whole family. I'm like the grandma of the camp. I help all the moms with the babies, and I just want to talk to somebody. And I've thought of taking my life once in a while, but I feel like I have a purpose, and I just want to come and say hi to you guys and thank you, and just talk to a human being for 5 minutes.
Yeah, thank you very much for your service too.
Uh, that's crazy. Did you, in the times you've been there, have there been things that you realized would be good to have or that are needed that hadn't been recognized before that you brought in terms of medications or equipment or things like that that
Well,
accrue?
it's a good question. We have begun to think about so simple things. So there's a lot of, in field medicine, there's a lot of fun things you can do. So we have simple things like glucometers, right? They do need AA batteries, but those are available everywhere in the world. And you can watch someone's, diabetes, blood pressure cuffs are so easy to get now. You can prevent disease, especially preeclampsia and pregnancy. It's important to check. So simple things like that. Cholesterol checks are so easy to do now. Um, the other big thing I love, helping out if I can, is I'll try and bring, if I can, someone donates it to me or helps me out, is I'll bring in a small oxygen generator because there are a lot of children in the camp who need oxygen. And I had this horror story, maybe a couple of years into when I was maybe 5 years ago, 6 years ago. The power, basically, we had no power for a few minutes, maybe 20, 25 minutes. And there's a child who'd come to charge his oxygen generator, and he had cerebral palsy. So his oxygen, I'll never forget. I mean, the mom came crying to me. I was in a room next to her. I had no idea what's going on. I ran over. This child is breathing fine, but his oxygen saturation was like 72%, which should be 95%. And there's nothing I could do. I mean, his battery hadn't charged yet, so his oxygen generator wasn't working. They would charge it every 2 days, in the clinic and go back. So, things like that certainly helpful. So portable equipment that we can use. I learned a lesson the hard way. If mom's bleeding, by the way, I have to say, ChatGPT answered this question right for me. I was impressed recently, but I've known this for a long time. If a baby's born and the mother's bleeding postpartum and a uterine massage isn't working, the first thing you do is you put the baby to the breast. You breastfeed the baby, and you have natural oxytocin release, and the uterus shuts down. So, simple things like that in field medicine help. But we always try and bring. Now I always have a small pulse oximeter in my pocket. COVID taught us a lot, so you can buy these very inexpensive pulse oximeters. They're battery operated. That you go on your finger. So we have all these small devices we bring with us now to just provide care. It really helps us provide care. We are data driven, unfortunately, so we like data. And so if we can find machines that can help us, we do take them with us.
And what we hear since the fall of the Assad regime is that people are flocking back to Syria. What do you hear from Al Zaatari?
Yeah, I mean, there's so much. I mean, there's so many different places. We're trying to actually get to, if we can, to the Egyptian border to provide care there. I mean, there's people definitely going back, but it's a mixed bag. They are providing care in some areas, but the hospitals are poorly outfitted in Syria and Damascus. So it depends on where you are. It's I'll tell you, as a physician, I never realized such importance of nutrition. Right. So I've seen scurvy in the camps. Someone comes in and they're not eating citrus. They don't even think about it, right? You don't see citrus available that easily all the time in the desert unless it's brought to you or shipped in. So I've seen, I've seen somebody looked at the mouth, they're bleeding, like, what's going on? I'm like, well, you're vitamin C deficient. Like, we give them some vitamin C, a bottle of vitamin C. So it's simple things you normally wouldn't see, in the US setting, but you just see it because it's there. So I think there are definitely changes happening with time, but long-term displacements become an interest of mine because everyone focuses on acute orthopedic trauma, acute surgical trauma, but post initial acute injury, there's a chronic displacement issue, and a lot of it's bred with overcrowding and then malnutrition. I'll give you one last example. If a mom does not have folic acid in her diet, the child is born with neural tube defects. So
Yes.
it's so simple to prevent, but can we do it?
Do you have any other questions?
Yeah, thanks again, Lewis here. I wondered if the refugees have any kind of access to hospital care if you come across that kind of a case. Is there some coverage for costs involved, so forth, in hospital care? And then immunizations. You didn't mention immunizations exactly. Maybe it's on that road to health card, but are they immunized as well? And then,
They are immunized, do but sadly, a lot of them run away from immunization because they don't trust immunizations. So absolutely. So you know what the UNHCR uses is their cell phones. So everyone's got a cell phone. So they can track everybody and they can track them by cell phones for the immunizations. So they send messages out, blasts of immunization, but
Wow.
very few will come in. Acute care actually isn't too bad. So when the patient's really sick, they can get to a Jordanian hospital. The care is paid for by UNHCR IMC,
Okay.
but it's very, very, it's uncommon.
Okay, good. Well, that's good care then. Yeah.
Well, thank you once again. This was
Well, it's really a pleasure. And maybe I can
wonderful.
give you all an update next year and maybe a different trip. I'm planning to go to a couple different trips, one to Greece and one probably to the Egyptian border. So we'll let you know what happens there.
We're looking
Oh,
forward
good
to it.
luck.
Yes.
Yes.
Thank you.
All the
It's a
Thank
best.
you.
pleasure. Thank you for seeing us tonight. Thank you. Bye-bye.